now with Dr. Justin Kwan. And, I invited Justin on the podcast because, well, first, when we did a episode, Justin, a couple months ago live, we did sort of hard questions. And, one of the things I have been thinking about, and you can probably correct the metrics a little bit better, but when I've looked at the metrics on the evidence for myopia management, just general myopia management, not one specific intervention. We can talk about specific interventions, but just generally. And you hear terms thrown around like standard of care, and it's very important for all of these other reasons. But when I look at the data on the number of people that are actually doing myopia management in their practice, it still seems really low, like exceedingly low. And so maybe you can talk about that in a second, but I actually want to dedicate this episode to, if I were going to be a skeptic of myopia management, and to be clear, everybody watching, you can jump on and ask other questions that make you skeptical of myopia management. And what I try to do was scour evidence-based, scour critical thoughts on myopia management. And the whole idea, Justin, is if we're critical of these ideas and we address these criticisms, which some of them could be, that I actually think they're legitimate concerns.
Yeah.
And if we address them head on, maybe we can remove doubt or wonder about why we might want to hold off on myopia management. And so I'm trying to be as critical as I possibly can be with these questions that I've got for you. For the audience, I do not give these questions to the person I'm interviewing. Obviously, Justin knows we're going to be talking about myopia management. Obviously, he knows I'm going to take a critical approach, but he doesn't know what questions I'm going to ask. And so, but he's thought a lot about this. My suspicion is I'm not going to hit him with anything he doesn't understand the answer to. At least I'm hoping that he can give me some insight, because I don't have a hard answer for all of these either. So, Justin, thanks for playing today.
Yeah, challenge accepted. Thanks for having me back on, Chris.
Awesome. Okay, so the first thing that I want to think about is, the American Academy of Ophthalmology in 2022 released basically a position that came out and said, according to the AAO, most people with myopia don't experience serious vision loss, as it tends to be mild or moderate in most cases. So what do you say to that, and why should that not allow us to, why should that be compelling? Why shouldn't that be compelling as a reason that we don't use myopia management?
Yeah, so I guess it's always good to put ourselves in the shoes of the Academy of Ophthalmology and kind of the circles they run in versus what optometry might. We know in ophthalmology, a lot of residents going into fellowship are choosing retina over pediatric ophthalmology. And you can talk to any retinal specialist and they'll see the complications due to myopia. And yet we don't see a lot of that in our average family practice for optometry. We don't see the myopic maculopathies, and that, I think, makes us skeptical. Is this really as bad as these odds ratios or these prolific researchers say it's going to be? And a part of that, it's coming, and a part of it, it's already arrived. It's here. We just don't see them because they've been referred off or sent out. And I think there's a bit of human bias there, right? Because our recall bias, our ability to remember things, really stems on the most severe cases. And maybe we don't have a good system in our practice for, tracking those that maybe have moved away or have, lapsed a couple of years in their comprehensive eye exams. And so I think if we kind of take that perspective, we'll eventually find, we will find what we're looking for, as is the case with like Demodex, right? We see Demodex a lot more now that our radar is up and looking for it. So I'm gonna go back to the data just for a second. It essentially is, if you grab all the -4s in the world, 2% of them will have myopic maculopathy. You could say 2% is a small number, or you can say 2% is a large number, because 2% of adults 40 and older will get primary open-angle glaucoma. So that's where I kind of marry those 2% together, and we absolutely treat glaucoma very seriously.
You're speaking my language. Honestly, you're speaking my language when we talk about prevalence data, and specifically with glaucoma. So, even if we just consider like all the things, if we're talking about glaucoma, if we consider all the things, all the factors that make a patient with a glaucoma suspect, and we think about patients over the age of 40, think about all the things that look funny about an optic nerve that make a patient at greater risk, intraocular pressure that's elevated, family history, and you kind of total even that first one up to a whole lot of other things. You could get 10% of the population that would be at risk for glaucoma, even though only 2% of them have it.
And maybe not like there's a lot of mild, moderate glaucoma that won't ever lose central vision or have paracentral scotomas, and so do we still care? Yes, we still care.
Yeah.
Yeah.
Okay. Compelling. All right. Next one. A Cochrane review in 2020 found that while interventions like orthokeratology and atropine have some evidence of slowing myopia progression, long-term data on their effectiveness in reducing future complications are still lacking. What do you say to that?
Mm. Yeah, so I see this on like ODs on Facebook and other places. Doctors are skeptical. They get almost triggered by tying the child with myopia today to a potential same child, but as a, grown adult 40 years later, and saying, can you actually say that that myopia today will increase the risk of that condition tomorrow? And I take a step back and I think, have we studied like, I don't know, teenagers and their eating habits and who will have cardiovascular complications in 40 years? And the people will say, like, yeah, you can't fund that study. It's way too expensive and you would have lost the follow up. But why is myopia held to that higher standard, if you will, when there aren't a lot of clinical trials anywhere that are longer than 3 years for any disease state? Um, so I guess the Cochrane Review would have to, just review the evidence that's available, and there's been maybe a one or two more since that 2021. And the good news is, yeah, when you treat the children and we consider things like number needed to treat, and these interventions are very effective when you catch them when they're 7, 8, 9 years old. And it's not too late for the tweens, the teenagers, and maybe even the young adults. But then that that benefit is very much smaller. And so if you treat a patient for 5 years or you treat a patient for 7 years with myopia control, the most value is going to be in the first few years. I don't know if that completely answers your question or not.
Well, no, I mean it does. I think the main thrust of your point, again, you're speaking my language, although you're the wizard in myopia. I've likened this to a study that, an expectation that we will need to have, if supplementation in patients who have low macular pigment optical density, where just by just natural improvements in their carotenoids, or supplements, or just natural increase when they're 40 and they do not have any signs of macular degeneration, is it going to benefit them by the time they're 80? We don't have a study that's going to show us that, and it's unrealistic for us to expect a study that's going to show us that. But do we have a whole lot of studies that get us logically in that space? Yeah, we do. And so you can make those reasonable clinical connections even though we don't have a large study. Now,
Particularly because the anatomy and physiology follows in that vein. It's not just theory, right?
yeah,
Yeah,
exactly
yeah,
right. Yeah.
yeah.
So I think that's great. Let me move on to the next question. So this is about the natural plateau, and actually, this study is, one of our. I don't think she doesn't think that myopia management is. I don't think she doesn't think it's worth it. Maybe that's not the right way to say it, but this is a paper from Carla Zadnik, and so again, I'm taking a piece of the paper. This is a 2020 paper published in Ophthalmology called "Myopia Progression and Its Natural Course," and basically the summary, or one of the summary points could be from that paper, is that the research suggests that myopia progression naturally slows or stops by late adolescence or early adulthood in most individuals. And so by the time you're going to get to these patients, for the vast majority of them, they're already going to naturally slow. So what do you say to that?
Yeah, I think great work has been done in the past few years where every year that you get older, you do naturally slow by 15% in your myopia progression. And that's axial length and diopters. You're going to naturally slow 15%. Is it worth it to bring those cars to a stop rather than a 15% slowdown? It depends. What is the absolute level of myopia? we always try to guide our fellow doctors to say the actual goal is to not to keep treating until they've stopped naturally. It's to graduate them from high school no worse than -3. So the case example would be you would have a senior in high school who's -1. Don't treat. They're slowing either way, but they're gonna be okay at -1 and
Hmm.
maybe -150 by the time they're 24 years old. So don't treat that one. But for the seventh grader who's also naturally slowing down to the average age of stabilization, that seventh grader that's gonna maybe start to slow by age 16, maybe 18 or 19. We still deserve to try to say we owe it to that patient to save every diopter we can. Will we get there with 5 years of treatment? Maybe not. But if we can save three-quarter diopter, that still reduces the risk of myopic maculopathy. So yes, I think if we take the slowing of progression out of context with the patient and their age and their diopters, then we could make more generalizations like, oh yeah, then if they naturally slow, what's the point? Like a -6 is just as visually impaired when they're uncorrected as a -7. What's the big deal? We have to remember back to why each diopter matters.
Well, and I think, yeah, I think that again, this is making, this is a criticism of
Mhm.
maybe a point of even just an opportunity to say you got to get to them as early as you can.
Yeah,
So
yeah.
so then I take from this, obviously this study wasn't being critical. I don't think they were necessarily being critical, but they were just pointing out that, myopia progression is naturally going to occur. And if you infer that it's going to naturally,
Slow.
myopia progression is going to naturally slow, and if you infer that, well, at some point, it's already going to slow anyway, so it's not that big of a deal. I would say on the other side of it, and that's part of the reason for this discussion is, you know, why aren't we getting these? Why aren't we? Where are the 6-year-old to
Mm-hmm.
8-year-old early myopes going?
Mm-hmm.
That is a still a question that you and I have pondered,
Mm-hmm.
but I'm not sure. I'm not sure I have the answer to that. Um,
Yeah. Yeah,
which is
I
the other side
just
of this study of the point of this study.
yeah. Outside of Illinois, Kentucky, and one other state, it's not required for kindergartners to get eye exams before
Mm.
school. And so I think a lot of plus a halves are becoming minus a halves, and they are not seen till they're 9 years old, -2.
Mm.
So we need to kind of catch the pre-myopia into that minus a half myopia and start treating then. Yeah.
I think the next question I have kind of surrounds a couple different points that we could take this in a few different ways, but obviously there was a publication again 2020 cost considerations in myopia management for children in clinical and experimental optometry, and basically what it found was that many parents were hesitant to invest in myopia management treatments due to concerns over their cost effectiveness, especially for mild or moderate cases. What would you say to
Mm-hmm.
that?
Yeah. Mild or moderate cases are static because it's like I did an eye exam today and the child has mild myopia. Goes back to the previous point. Where do they come from and where are they going? So, yeah, we don't have to treat a mild myope if they just stayed that way, but growing children get worse 90% of the time. And so I think that at least I appreciate how they said unwilling to invest rather than unwilling to pay, because
Hmm.
at least they can see there's value worth investing in, like our stock portfolios, like we're investing and hoping they pay dividends. Even when we stop putting money in, that's the idea of that compounding interest is that it grows. So I know it's a crude financial analogy, but this is an investment that continues to pay off even after you stop treatment, and that's so valuable. That really kind of I think commands respect because you would have to keep taking your metformin for your lifetime and your glaucoma drop or for your lifetime. But with myopia treatment, it's not forever, and you get to still live into those adult years having baked in that benefit. So I would say, yeah, mild moderate is existing in a static place, and our patients are in a dynamic growth period.
There's an uncertainty. This opens up a question that I hadn't planned, but there's an uncertainty of static and mild to moderate that I think is in the back of all of our minds. Maybe it's not in
Mm,
the back of yours, but it certainly is in my mind when I'm sitting in front of a patient.
Yeah.
and their parent, and they're asking me, well, how much are they going to progress? And I can't
Mm.
know that. It's just
Mhm.
unknowable, and
Mhm.
that
Mhm.
leads to uncertainty, and that uncertainty then is picked up by the parents,
Yeah.
which means that then it comes back to, is part of the hesitancy to invest from the parents due to my hesitancy because I'm uncertain in how quickly those patients are going to react. What do you think about that?
Yeah. It could absolutely be that because, we all pick up on non-verbals more than the actual words that are coming out of our mouth. And it can be frustrating because, putting myself in your shoes again, it's just, we can only give them averages. Like a 7-year-old is going to progress, 0.75 on average. Could be a quarter, could be a diopter and a half, and we don't have the crystal ball to predict the future for your child. But we do know that as a whole, yes, treating growing children at age 7 is going to be so, so important to not miss that window because we can't go back. We can't make a -3 back into a -2. So it's, I guess, the quantifying the amount of uncertainty without teaching our patients biostatistics, right? We can just say more times than not, growing children get worse, and it would be a disservice for me to not treat your child in their rapidly growing years.
Yeah, absolutely. I got a comment. I want to, Mariana, I know you're on, you're listening. Would you chat me if there's any comments or questions that come up, and we'll just take them,
Cool.
chat me what those questions are, and then I'll ask them to Justin. So anybody that's listening on live, just just jump in if you've got something that you're skeptical about that makes you hesitant. Jump on. Mariana will send me a WhatsApp, Mariana, and then I'll ask them to Justin. So thanks, Justin. Thanks for
Yeah.
playing. This has been helpful for me. All right, so this is a big one, and I worry. This is actually a criticism that has gone through my mind years ago, and actually, again, I wonder if this is my buddy Sean Vitale, but I don't think it is. But anyway, Vitale et al. This is from Prevalence of Myopia Among Adults in the United States. Actually,
Yeah.
basically discussed that myopia affects about 30% of the population, but some argue that it's become over medicalized, given how
Mm.
effectively it can be managed with simple corrective lenses. So, are we medicalizing a disease or a condition that just doesn't need to be medicalized?
Mm-hmm. I think that's like a sizable gap that we're trying to bridge is like that refractive error to the medical part. And ICD-10 code or not, there are very real changes in the retina as we take our wide field retinal imaging every year for these patients, and we see the lattice, we see the peripapillary atrophy. You have a patient like me who had a posterior vitreous detachment at age 36, and that's not over medicalized. I lived through that. So
Mm-hmm.
I think that's the context where we have to step into and realize like we're going to be dilating our patients more often when they have moderate myopia, earlier decades of life when they're more likely to have these PVDs. And I would say, no, it's not over medicalized when you can see the anatomy and physiology change compared to an emetrope or a hyperope.
Take me through that then, Justin. It's been a while since you and I have talked about. So, um, we've talked about the 2% risk for myopic maculopathy at age 40, but where does that start to change? You said 4 diopters. Take me through that
Minus
really
four,
quickly so
yeah.
I can, yeah. So take me through, think about maybe myopic maculopathy, glaucoma risk, retinal detachment risk, even just, forget about a retinal detachment. It's not an insignificant thing for a patient. You mentioned posterior vitreous detachment, but, you've got patients that, I mean, I've seen studies where patients, a PVD for a patient that with a persistent floater. I mean, we've got surgical interventions,
Mm, mm-hmm,
laser surgical interventions for floaters that have basically a 50-50 efficacy, right?
mm, mm-hmm, mm-hmm.
So can you take me through that? So again, maybe I can think about like this, like all these other sequela in a way that
Yeah.
kind of reframes that in my mind. So I am not just relying on you to say it's
Mm-hmm.
not medicalized.
Yeah, yeah. I mean, I'm not going to cherry pick like, oh yeah, patients could get more than one condition, which is absolutely true, but I think let's look at the more common things that can happen. So if you step up from a -4 to a -5, then instead of 2% of all -4s get myopic maculopathy, it's going to be somewhere like maybe 5% of all -5s and 6s or something like
Hmm.
that. So now
Which is
one
one
out
in
of 20.
20. Yeah.
1 out of 20. Yeah,
Yeah.
yeah, yeah. And I will cherry pick one case because the story is important. There was an OD in Southern California. She has a 32-year-old son. He's in a critical care pulmonary fellowship, age 32, and he got myopic choroidal neovascularization. And your heart breaks because he has to live 2/3 of his life with visual impairment. Not to say that if we had saved him 2 diopters that he wouldn't have, but that risk at least was again deserved to this seventh grade, pre MD. I don't know when he
Yeah.
decided to go into this, but um, so there is just so much retinal disease. Like glaucoma is one thing, and I really love this glaucoma study where I met this guy at an Arbo conference. He was doing his PhD. He kind of just like set up camp at a LASIK center in Hong Kong. He's of
Hmm.
Indian descent. And he was just like looking at RNFL thickness, he was looking at visual field defects. He eventually published a paper, but that really is kind of eye-opening that patients with myopia that are getting LASIK, they're in their 30s, sometimes they're in their late 20s, and they have an RNFL like a 60-year-old because of that
Hmm.
mechanical from axial elongation and the stress on the RNFL and these are again more paracentral scotomas that they're picking up and maybe we could do more 10-2s on these folks, which was a different Arvo poster I put together one year. But the glaucoma thing is substantial, but it's not as large as the myopic maculopathy part of myopia. So if you look at that, often referenced table of like how many X by condition, by diopter, the glaucoma one doesn't exponentially increase in the same fashion as
Hmm.
myopic maculopathy.
It's interesting because even as I think about this, you know, because something like as a profession, why do we trivialize some of these
Mm,
things where, other professions don't do that? You look at like reducing the risk of strokes and heart
yep.
attacks with
Hmm.
lowering cholesterol.
Statins. Yeah.
Again, like there's a lot of debate on that, but
Yeah.
but and as a profession as a whole, that generally speaking, there's not a lot of debate on whether or not we should at least help patients in certain scenarios. Maybe
Hmm.
use
Hmm.
if you use a medication or don't use a medication. There is some debate about that based on other risk
Hmm.
factors. But the point is that like we tend to be a lot of the things that you point out. Why wouldn't we care a whole lot about trying to reduce those risks for people?
Yeah.
And the other thing, I mean, I guess so. I think that's interesting, and it's helpful for me to kind of re-remember some of those numbers.
And
Let
I
me move
think
on to the
maybe
next.
also
Yeah.
a lot of these parents of the children are like, I was a -6, I got LASIK, I'm fine. And like,
Yes.
you're fine
Yes.
until you're not, I guess.
Yes.
It's
Yeah.
still baked into your retinal. Your outer retinal layers have already have taken the hit. The damage has been done because you became a -6 through your adolescence. And so I'm fine is like, until you're not. Yeah.
Yeah. So okay, I'm gonna give the floor over to some of the commenters. So here's another kind of follow up question. While myopia isn't glaucoma, there are parallels, especially when looking at suspects. What's your advice on when to manage myopia with an intervention versus managing via observation?
Mm. Yeah, our colleague Dr. Josh Rajasansi says this well. Once that refraction tips into myopia, that's like your check engine light. Like you gotta jump on that. You gotta take care of it. Something is wrong. The system couldn't take care of itself to emmetropize, and now we're in the myopia bucket. And you don't get out of the myopia bucket,
Mm,
provided it's cycloplegic and you're sure it's myopia.
yeah.
So there isn't in glaucoma, we're monitoring the suspects on risk factors, corneal thickness, and everything like that. Um, I guess the observation period would be for pre-myopia when they're plus a half hyperopia. So anything less than 0.75 in your first through sixth grade kind of age group, plus a halves and plus a quarters are pre-myopia. So that would be the only place I would recommend observation is in that if those two criteria are met. Plus a half, plus a quarter, first through sixth grade. Um, all other times, once you're minus a quarter or worse, we're treating.
Hmm.
We ought to be treating.
Yeah, or at least giving the option for treatment, trying to
Yeah,
remove ourselves as the barrier for treatment.
yeah, yeah.
Fair. Okay. All right. So let me pose another one. So there was another Cochrane review that this is about inconsistent standards. So when we look
Mm,
about at a lot of the different studies, there's different standards, there's different
yeah.
amounts of atropine, different types of orthokeratology lenses. You can certainly talk about the intervention that Cooper has. So points out. So as a criticism, Cochrane kind of pointed out the lack of high quality long term randomized controlled trials to treat strong to create strong guidelines for myopia management,
Mm,
highlighting inconsistencies across treatments. I'll tell you, as a clinician, it's absolutely frustrating to me when
mm,
because it's not as predictive, the same things that we've talked about. So what
yeah.
do you say about that?
Yeah, so I'll take it back to hemoglobin A1C. We know that blood work gets done every 3 months. Yeah, and with myopia's kind of decades or centuries long development in the research space, it wasn't until the International Myopia Institute started gathering the brightest minds across the world to put out their reports, not unlike the dry eye workshop, the MGD workshop, and the TFOS group, and all the collaborative work they've done. So I would say as of 2019, there have been better guidelines. And even some of the consensus statements don't give a protocol per se, right? But I do reflect back, Chris, on the LAMP study, the ADAM study. Like these atropine studies that are typically in younger children follow patients every 4 months. I think we can borrow that for clinical practice.
Mm-hmm.
Let's see these atropine patients every 4 months. And you look at the optical intervention studies for myopia control, and they follow patients every six. I think that's very reasonable, particularly in the age group, the patient demographic with the intent to treat. So yeah, every four for atropine and younger, every 6 months for third grade and older, if you will. I think are very reasonable places to start and look to the IMI for these protocols, which have been refined because they published again in 2021 and again in 2023. So the pace is quite astounding, which the collection of the body of literature is distilled into these IMI reports, offering us as clinicians these guidelines that we can put to use tomorrow.
So Justin, if somebody were going to search that, somebody that was watching right now wanted to search it, IMI. I'm not sure I can
Uh,
jump in. Mariana,
yeah,
maybe if
IMI
you can comment.
myopia.
Yeah.
It's freely available for download. The IOVS journal puts out the IMI every 2 years.
Okay. Great. All right. So last question I've got, and then I do have one more question from a
Great.
viewer. So, all right. So again, I'm gonna play devil's advocate. I kind of know the answer already, but 2021 a meta-analysis in ophthalmology, outdoor time and its effect on myopia onset. So meta-analysis found that increasing outdoor time significantly reduced the risk of myopia onset,
Mm-hmm.
suggesting that a simple lifestyle change may be just as effective as medical
Mm-hmm.
interventions.
Mm-hmm. Mm-hmm.
Where are we going wrong there?
Yeah. Yeah, I know. I think
Slow pitch softball.
this is the thesis, I think, of Mark Bullimore's paper, an ounce of prevention is worth a pound of cure. So if he quantified the value of delaying the onset of myopia with outdoor time per se, that would be 2 to 3x as effective as a year of contact lens, ortho K or MySight, whatever you name it, right? So there is truth that delaying onset with outdoor time and reduced near work is very high efficacy. It gives the patient a large effect size in their myopia control. But that does forget the reality of today is that there are, in my estimation, 19.5 million children with myopia where you can't do anything to help them by sending them outside. But you can do a little, and especially in the winter, you can get them outside more. But they need an intervention that they can see clearly and uses light to change the growth of the eye today, and sending them outside would be doing them a disservice. This outdoor time is really for the younger siblings, the pre-myopes, and those that are trying to cultivate that healthier, holistic lifestyle, if you will, with time outdoors, and also send that bright light to the back of the eye to slow the growth. And then I think of countries in Asia like Singapore, China, that do have these public health efforts in within the school system too, to make sure these kids have plentiful outdoor time, 80 minutes more than they did 10 years ago. So those are effective, but we in the US at least are living in the reality that we still need to help the kids that have myopia already instead of trying to just delay the onset of those that are gonna be myopic. Yeah.
Yeah, well, I think that's probably the major point is the
Yeah.
confusion between myopia onset, and then
Yes.
once you have developed myopia, there really isn't a whole lot of, I mean, calculable or studied
Yeah.
benefit from the outdoor activities. Is that still correct? Do we have any more studies? I
Yeah,
haven't
that's
been able to
mostly
find one.
correct. Yeah.
Yeah.
It's kind of one of those things where it's equivocal. Like you can find studies on both sides, but there's not a clear winner of does time outdoors slow myopia progression that has already onset. I stand in the camp that yes, it does because you're still releasing dopamine. It's still a strong stop signal for axial elongation. You look at the seasonal winter faster than summer. That's why I believe you still
Mm.
can get some control from time outdoors when you have myopia.
Do you think it's more about the outdoor activity is more about dopamine release, or do you think it's more about distant activities?
Mm-hmm. From what I've read, Chris, I firmly believe it's more dopamine release than like this flat, dioptric, less accommodative, relaxillary
Mm.
body. Because we know that when you paralyze accommodation, there are still signals that can make myopia get worse. So it's complicated because International Myopia Conference is happening right now. I bet you that's being debated left and
Well,
right.
so I
Yeah.
actually, so I would actually, and I don't know the answer, but
Yeah.
my inclination is that, I mean, it might be dopamine. I would entertain that, but don't we get a lot of dopamine from doing this,
Mm-hmm.
right? So
Yeah.
doesn't scrolling and gaming and all that kind of stuff on
Oh
this
yeah.
release dopamine?
Dopamine, not from light levels, because while our phones get brighter and brighter, it's not nearly the 200 times brighter as being outside. Now, systemic dopamine for like, positive
Ah,
reward
okay.
is different. That goes to the brain level, not your outer
And
retina
that's not
level.
high enough to change the
Yeah.
dopamine levels in the choroid, for example.
Not that I'm aware of.
Interesting.
Yeah.
Well,
Yeah.
that would explain it then, right? That
Yeah.
would
Yeah.
explain the difference between the dopamine. So, yeah, I hadn't thought about it like
I
that, but
think
that
there
makes sense.
are pipeline companies looking at trying to get dopamine release in the outer retina.
Yeah.
So folks that are
Hmm.
curious about that can Google search that. Yeah.
All right. Cool. All right. So, last question. This is more of a, if I were going to round this out, I have no more skeptical questions for you right now. I think that's all of them. I can't. I think I
Yeah.
had about 10. But last question. So, how can we share success with parents of what? How can we share with parents? This is a reader or listener question. How can we share with parents what success looks like? The road is
Okay.
long. If you start with an 8-year old, and encouragement for both the parent and the patient is important. But how do we set the path for success when they may come back as a 9-year old and have
Be
a
worse.
click more minus, or
Yeah.
how do you share that with them?
Yeah. So, kind of part of the conversation, or at least maybe written in your parent-doctor agreement, when they start the myopia control program, is slowing of progression is expected, but it's not guaranteed, and that's pretty boilerplate. Or just tell them, hey, all the studies that we can find can slow this by about half. We'll get better at times. We'll not do as good in other times, and no treatment that's FDA approved or not works perfectly. That's the unfortunate reality, but my job is to be with you every step of the way and see if we need to change course and do something a little bit different to ensure your child graduates high school no worse than -3. So you can say, like, tell your own story. You can tell your personal one, or maybe a patient you've treated in the practice. Like, we started these 8-year-old twins, and we started them when they were -0.5. And 3 years later, they were no worse than, -0.75. But then they had a growth spurt. When they turned 11 to 12, they jumped -0.5. They were still wearing their MySight one day, full time, 12 hours a day, and they were thoroughly enjoying it. But sometimes these things can happen, and growth is not linear. We all hit our growth spurts at different ages, and so the hope is the next visit they'll be stable again. So yeah, I think stories go a long way because you
Yeah.
can't deny that you actually treated that patient in your practice.
Right. No. And I think even, part of it is the setup at the beginning, right? Is communicating the uncertainties effectively when you start, but then also being able to communicate them again when they do have that half diopter shift.
Yeah,
Um,
yeah,
and then I guess my follow up to that would be, when do you say, okay, we need to add a different intervention, right? So you
yeah,
talk about
yeah.
my site, and obviously what you're going to say probably now is all off label,
Hmm.
but the reality is that sometimes we have this gut reaction to say, well, no, this is too much, and what is too much, and
Hmm.
when do I employ something else? What are your thoughts about that?
Yeah, I'm just trying to make it as simple as I can. So we just always kind of come back to this proven point that the younger the child, the faster they get worse. So if I just draw a line at 10 years old, any child younger than 10, you're going to see progression even when they're treated well.
Mm.
Yeah, so if you have my side on a 9 year old, they're going to progress a quarter or a half or sometimes 75 in a year, and maybe a quarter at the 6 month. That's actually expected. That's good. That's not zero, but that's what you set the parent up to expect. Older than 10, you should be expecting zero diopters of change almost
Mm.
every single
Oh,
year.
that's super
Yeah,
helpful.
yeah, yeah.
That's super.
Hmm.
Actually, that the way you explain that there, I think, is probably the best way to set up a conversation with the parent to communicate the uncertainty at the
Yeah,
beginning.
yeah,
Is that
yeah.
I want as little myopia progression as possible before the age of 10, but a
Hmm.
quarter to three-fourths of a diopter can happen
Exactly.
even with this intervention.
Yeah,
But
yeah.
after 10, I expect almost nothing with this intervention.
Yeah. And
That's
a really quick point, Chris, because I remember a lot of doctors might say from the podium that once I see 2 years of stability, I entertain removing treatment. But I caution against that because, again, back to it's not perfect, but you wouldn't take metformin away and expect the blood sugar to be stable.
mm-hmm.
Or just because their A1C was at 6.2, 6.2, 6.2, it doesn't mean you stop your metformin either. So remember again that it's age and RX both, and stability is what you want to see, but stability is not a signal for the doctor to remove treatment. We
So
have to balance everything. Yeah.
would it be reasonable to say stability 2 years after the age of 18 is
Yeah,
a
it's a sign
qualifier
to
that might
stop.
make us feel more comfortable?
Yeah, or even after 16, I would
Okay.
say. Particularly if they're, below -3. Yeah.
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 Okay.
That's a
Um,
good pearl.
yeah, that is very helpful. Okay. Well, I don't have any other questions, and it doesn't look like our viewers do. Dr. Kwan, thanks so much for coming on again. I appreciate the opportunity to pick your brain. I think this helps me with uncertainties. I hope it helps the audience with uncertainties. Any other final thoughts?
I would just say that, like, remember how quickly word of mouth referral can happen. I've seen that every day I show up at work, is that um, we maybe or we fail to kind of comprehend how much parents talk to each other.
Mm,
And I think that should be a word of encouragement, or to either do more myopia control and not kind of let that slip by in your everyday busyness, if you will, but to know that the rewarding aspect of it will continue to compound and make showing up to practice that much more worth it, because of the community that wants to help their children from getting worse. So get started. You might hear 5 no's tomorrow, but you might hear 4 yeses the very next day. So that's the
awesome.
reality.
Thanks. Dr.
Yeah.
Kwan, appreciate
Yeah.
it.
Have a great day. Bye,
You
everyone.
too. Thanks, everybody. Thanks, everybody, for jumping on. We'll see you on the next one.